Spina bifida represents one of the most significant congenital malformations affecting the human nervous system, occurring when the neural tube fails to close completely during early embryonic development. This developmental anomaly results in incomplete formation of the spine and spinal cord, creating a spectrum of conditions that can range from virtually asymptomatic to profoundly disabling. Understanding this condition requires examining the intricate processes of embryological development, the various factors that can disrupt normal formation, and the wide-ranging clinical manifestations that affect individuals throughout their lives. During the earliest stages of human development, approximately 3 to 4 weeks after conception, a critical process called neurulation takes place. The neural tube, which will eventually develop into the brain and spinal cord, forms from a flat sheet of cells called the neural plate. This plate folds inward, and its edges gradually fuse together to create a closed tube. When this fusion process fails to complete properly in the lower portions of the developing spine, spina bifida occurs. The term itself derives from Latin meaning split spine, which accurately describes the fundamental anatomical defect where the vertebral arches fail to fuse posteriorly, leaving the spinal cord and its protective coverings vulnerable. The causes of spina bifida are multifactorial, involving complex interactions between genetic susceptibility and environmental influences. No single gene has been identified as the sole cause, though research has revealed that multiple genes involved in folate metabolism and neural tube closure play important roles. Families with one affected child have approximately a 2 to 5% increased risk of having another child with a neural tube defect, suggesting hereditary components. However, the majority of cases occur in families with no prior history, indicating that environmental and nutritional factors carry substantial weight in the disease's etiology. Folate, a B vitamin essential for DNA synthesis and cell division, has emerged as critically important in preventing neural tube defects. Women with inadequate folate levels during the periconceptional period face significantly elevated risks of having children with spina bifida. This discovery led to one of public health's greatest successes: mandatory fortification of grain products with folic acid in many countries, which has reduced the incidence of neural tube defects by approximately 50 to 70%. The mechanism involves folate's role in 1-carbon metabolism, which is essential for the rapid cell division and methylation processes occurring during neural tube formation. Genetic variations in enzymes that process folate, such as methylenitetrahydrofolate reductase, can impair folate metabolism even when dietary intake seems adequate, explaining why some women require higher supplemental doses. Beyond folate deficiency, several other factors increase the risk of spina bifida. Maternal diabetes, particularly when poorly controlled during early pregnancy, substantially elevates risk through mechanisms involving hyperglycemia, induced oxidative stress, and altered gene expression during neurulation. Women taking certain anti-epileptic medications, particularly valproic acid and carbamazepine, face significantly increased risks, as these drugs interfere with folate metabolism and may have direct teratogenic effects on developing neural tissue. Maternal obesity has also been associated with higher rates of neural tube defects, possibly related to insulin resistance, inflammation, or nutritional deficiencies common in obese individuals. Hypothermia during early pregnancy, whether from fever or excessive heat exposure in hot tubs or saunas, appears to increase risk, as elevated temperatures can disrupt the delicate cellular processes required for proper neural tube closure. Environmental exposures to certain chemicals and toxins may contribute to spina bifida development, though definitive evidence for specific agents remains limited. Some studies have suggested associations with pesticide exposure, organic solvents, and heavy metals, but establishing causation is challenging given the multifactorial nature of the condition. Geographic and ethnic variations in incidence rates suggest that both genetic and environmental factors specific to certain populations play roles. Historically, higher rates have been observed in Celtic populations and lower rates in African and Asian populations, though these differences have narrowed somewhat with improved nutrition and folic acid supplementation. The clinical manifestations of spina bifida vary tremendously, depending on the specific type and severity of the defect. The condition exists along a spectrum, traditionally classified into 3 main categories: spina bifida occulta, meningocele, and myelomeningocele, each representing progressively more severe malformations with increasingly significant clinical consequences. Spina bifida occulta, the mildest form, occurs when one or more vertebrae fail to form completely, leaving a small gap, but the spinal cord and meninges remain in their normal positions without protruding through the defect. Many individuals with this form never experience symptoms and may live their entire lives unaware of the condition. It's estimated that 10 to 20% of the general population has spina bifida occulta, usually discovered incidentally during imaging studies performed for other reasons. However, some individuals develop symptoms, particularly during periods of rapid growth in childhood or following minor trauma in adulthood. These symptoms may include back pain, leg weakness, numbness or bowel and bladder dysfunction. External signs sometimes provide clues to the underlying defect, including a tuft of hair, dimple, birthmark, or small lipoma at the lower back overlying the vertebral gap. A condition called tethered cord syndrome can develop when fibrous tissue, fat or bone abnormally attaches to the spinal cord, restricting its movement and causing stretching as the child grows, leading to progressive neurological deterioration. Meningocele represents an intermediate form where the meninges, the protective membranes surrounding the spinal cord, protrude through the vertebral defect, forming a fluid-filled sac visible beneath the skin, but the spinal cord itself remains in relatively normal position. This sac contains cerebrospinal fluid and meningeal tissue, but typically no neural elements. Most children with meningocele have normal or near-normal neurological function, though some may experience minor disabilities. The visible sac usually appears as a soft, fluid-filled bulge on the back, most commonly in the lower spine. Surgical repair is necessary to prevent infection and protect the protruding meninges, but the prognosis is generally favorable with appropriate treatment. Myelomeningocele, the most severe and most common form of spina bifida, occurs when both the meninges and spinal cord protrude through the vertebral defect, with neural tissue exposed or covered only by a thin membrane. This form accounts for approximately 75% of spina bifida cases and results in significant neurological impairment. The sac containing neural tissue is visible at birth, most frequently in the lumbar or sacral region, though it can occur anywhere along the spine. The level of the lesion largely determines the extent of neurological deficit, with higher lesions generally causing more severe impairment. Neural tissue within the sac is often malformed and non-functional, and the exposed or thinly covered nerves are highly vulnerable to damage and infection. Children born with myelomeningocele face numerous complications affecting multiple organ systems. Paralysis and sensory loss occur below the level of the lesion, with the specific pattern depending on which spinal segments are affected. Thoracic lesions result in paralysis of the trunk and lower extremities, requiring wheelchair mobility. High lumbar lesions typically allow some hip movement but limit knee and ankle function. Lower lumbar and sacral lesions may permit walking with braces and assistive devices. Sensory loss accompanies motor deficits, creating risks for unnoticed injuries, pressure sores, and burns, as affected individuals cannot feel pain, temperature, or pressure in denervated areas. Bladder and bowel dysfunction represent nearly universal problems in myelomeningocele, resulting from denervation of the pelvic organs. Neurogenic bladder occurs when nerve damage prevents normal bladder control, leading to either retention or incontinence. Without proper management, neurogenic bladder can cause recurrent urinary tract infections, vesicoureteral reflux where urine backs up into the kidneys, and progressive kidney damage that historically represented the leading cause of death in individuals with spina bifida. Modern management with clean intermittent catheterization, anticholinergic medications, and careful monitoring has dramatically improved renal outcomes. Bowel dysfunction similarly requires management programs incorporating diet modification, scheduled toilet timing, medications, and sometimes enemas or surgical interventions to achieve continence and prevent complications. Hydrocephalus, an abnormal accumulation of cerebrospinal fluid within the brain's ventricles, develops in approximately 70 to 90% of individuals with myelomeningocele. Most cases are associated with a Chiari-Ezekiel malformation where the lower portions of the brain, including the cerebellar tonsils and brainstem, are displaced downward through the opening at the skull base. This malformation disrupts normal cerebrospinal fluid circulation and can compress vital brainstem structures. Untreated hydrocephalus causes increased intracranial pressure, leading to headaches, vomiting, lethargy, developmental delays, and potentially life-threatening brainstem compression. Treatment typically requires surgical placement of a shunt system that drains excess cerebrospinal fluid from the brain ventricles to another body cavity, usually the abdomen, where it can be absorbed. Shunts require lifelong monitoring and may need revision or replacement multiple times throughout life due to obstruction, infection, or mechanical failure. The Chiari-Secou malformation itself can produce additional symptoms beyond hydrocephalus, including difficulty swallowing, breathing irregularities, vocal cord paralysis, and sleep apnea. Severe cases may require surgical decompression to relieve brainstem pressure. Intellectual development in children with myelomeningocele varies widely but is often affected, particularly in those with severe hydrocephalus or repeated shunt infections. Many individuals have normal intelligence, though specific learning disabilities affecting mathematics, attention, executive function, and visual spatial processing are common. Language skills are often relative strengths. Early intervention and appropriate educational support significantly improve outcomes. Orthopedic complications arise from muscle imbalances, abnormal forces on developing bones, and paralysis. These include hip dislocation, clubfoot, scoliosis, kyphosis, and leg length discrepancies. Muscle contractures develop when denervated muscles cannot balance the pull of functioning antagonist muscles, leading to fixed deformities. Fractures occur with increased frequency due to osteoporosis from reduced weight bearing and altered bone metabolism. Orthopedic management requires ongoing monitoring, physical therapy, bracing, and often multiple surgeries to maintain or improve function and prevent deformity progression. Skin complications represent serious concerns given sensory loss and reduced mobility. Pressure sores develop when sustained pressure over bony prominences reduces blood flow to skin and underlying tissues, causing tissue death. These wounds can become deep, chronically infected, and extremely difficult to heal, sometimes requiring major surgical reconstruction. Prevention through meticulous skin care, frequent position changes, appropriate cushioning, and regular skin inspection is essential. Individuals must learn to perform pressure relief maneuvers regularly and inspect their skin using mirrors to check areas they cannot see directly. Latex allergy affects a remarkably high proportion of individuals with spina bifida, estimated at up to 70%, representing one of the highest risk groups for this condition. Repeated exposure to latex products during multiple surgeries and medical procedures combined with possible genetic susceptibility sensitizes individuals to latex proteins. Reactions range from mild skin irritation to life-threatening anaphylaxis. Strict latex-free protocols must be implemented in all medical settings, and patients should avoid latex products in daily life. Endocrine and metabolic complications include obesity, which develops frequently due to reduced activity levels, lower metabolic rates from decreased muscle mass, and sometimes hypothalamic dysfunction. Sexual development may be affected, with some individuals experiencing precocious puberty or delayed sexual maturation. Fertility is often preserved, though women with spina bifida face increased risks during pregnancy and require careful obstetric management. Psychosocial challenges accompany the physical disabilities as individuals navigate issues of independence, social integration, education, employment, and relationships. Depression and anxiety occur at higher rates than in the general population. However, with appropriate support, many individuals with spina bifida lead fulfilling, independent lives, complete higher education, maintain employment, and establish families. Diagnosis of spina bifida occurs through several approaches depending on timing. Prenatal diagnosis has become increasingly sophisticated, allowing detection in the majority of cases before birth. Maternal serum alpha-fetoprotein screening, performed between 15 and 20 weeks of gestation, detects elevated levels of this protein in approximately 75 to 80% of open neural tube defects. Alpha-fetoprotein, produced by the fetal liver, leaks into the amniotic fluid and maternal bloodstream when neural tissue is exposed. Elevated levels trigger additional testing, though false positives occur with multiple gestations, incorrect dating, and other conditions. Ultrasound examination provides direct visualization of the developing fetus and can detect neural tube defects with increasing accuracy as technology advances. High-resolution ultrasound in experienced hands can identify spina bifida lesions, measure ventricular size to assess for hydrocephalus and detect the lemon sign. Frontal bone scalloping and banana sign, abnormal cerebellar shape, associated with Chiari-Secou's malformation. 3-dimensional and 4-dimensional ultrasound techniques may provide additional detail. First trimester ultrasound can sometimes detect neural tube defects, though second trimester examination remains the standard. Fetal MRI offers superior soft tissue detail and can better characterize brain abnormalities, particularly useful when ultrasound findings are equivocal or when detailed information is needed for counseling and planning. Amniocentesis. involving sampling of amniotic fluid, can measure alpha-fetoprotein and acetylcholinesterase levels directly, providing very high sensitivity and specificity for open neural tube defects when both are elevated. This invasive test carries a small risk of miscarriage but offers diagnostic certainty when results are positive. Genetic testing through amniocentesis can also identify chromosomal abnormalities sometimes associated with neural tube defects. When spina bifida is detected prenatally, families receive counseling regarding the diagnosis, prognosis, management options, and resources. Fetal surgery for myelomeningocele, performed between 19 and 26 weeks of gestation, has emerged as an option at specialized centers. The management of myelomeningocele study demonstrated that prenatal repair, compared to standard postnatal repair, reduces the need for shunt placement, improves motor outcomes, and may preserve neurological function by preventing ongoing damage to exposed neural tissue during the remainder of pregnancy. However, prenatal surgery carries risks including preterm delivery, maternal complications, and uterine rupture in subsequent pregnancies, requiring careful candidate selection and extensive counseling. For cases not detected prenatally, diagnosis at birth is usually obvious when a visible sac or lesion is present on the back. Physical examination assesses the level of the lesion, neurological function, associated anomalies, and signs of hydrocephalus. Immediate protective measures prevent infection and trauma to exposed neural tissue. Imaging studies including cranial ultrasound or MRI evaluate for hydrocephalus and Chiari malformation. Spinal imaging characterizes the defect and assesses for other spinal abnormalities. Renal ultrasound establishes baseline kidney anatomy and function. For spina bifida occulta, diagnosis often occurs incidentally during imaging for other indications or when symptoms prompt evaluation. MRI of the spine provides detailed visualization of the spinal cord, nerve roots, and surrounding structures, identifying tethered cord, lipomas, or other associated abnormalities. Treatment of spina bifida requires lifelong, multidisciplinary care coordinated among numerous specialists. For myelomeningocele detected at birth, initial surgical closure of the defect typically occurs within the first 24 to 72 hours to prevent infection and minimize further neurological damage. The surgery involves carefully dissecting neural tissue from surrounding structures, reconstructing neural play code when possible, closing the meninges, and covering the defect with muscle and skin. This prevents cerebrospinal fluid leakage and protects neural elements, though it does not restore function to already damaged nerves. Hydrocephalus management usually requires ventriculoperitoneal shunt placement, often performed shortly after the initial back closure or when signs of increased intracranial pressure develop. Some centers perform endoscopic third ventriculostomy with choroid plexus cauterization as an alternative in selected cases. Families must learn to recognize signs of shunt malfunction, including headaches, vomiting, lethargy, irritability, or changes in consciousness, as these represent medical emergencies requiring urgent evaluation and possible shunt revision. Urological management aims to preserve kidney function, prevent infections, and achieve continence. Clean intermittent catheterization, taught to parents in infancy and to children when developmentally appropriate, empties the bladder regularly, preventing overdistension and reducing infection risk. Anticholinergic medications reduce bladder pressure and improve capacity. Regular monitoring includes renal ultrasounds, urodynamic studies assessing bladder function and pressures, and laboratory tests evaluating kidney function. Some individuals require surgical interventions including bladder augmentation to increase capacity and reduce pressure, or creation of a catheterizable channel providing easier access for intermittent catheterization. Bowel management programs establish regular evacuation patterns to achieve continence and prevent complications. These programs incorporate adequate fluid and fiber intake, scheduled toilet timing coordinated with natural gastrocolic reflexes, digital stimulation, suppositories or enemas as needed. The antegrade continence enema procedure, creating a catheterizable channel into the colon, allows administration of enemas from above, flushing the colon and establishing predictable bowel movements. Success with bowel management dramatically improves quality of life and social participation. Orthopedic care addresses deformities, maintains or improves function, and prevents complications. Physical therapy, beginning in infancy, promotes motor development, strengthens functioning muscles, maintains range of motion, and prevents contractures. Bracing provides stability, enables ambulation, and prevents or slows deformity progression. Surgical interventions may include releases or transfers of contracted tendons, correction of foot deformities, hip procedures to maintain or restore alignment, and spinal fusion for progressive scoliosis. The goals balance functional improvement, cosmetic concerns, and quality of life, recognizing that ambulation may not always be the optimal goal if wheelchair mobility provides greater independence and energy efficiency. Rehabilitation services incorporate physical therapy, occupational therapy, and sometimes speech therapy, addressing motor skills, activities of daily living, adaptive equipment needs, and developmental concerns. Assistive technology ranging from simple adaptive devices to sophisticated computerized systems enhances independence and participation. Mobility equipment includes walkers, crutches, braces, manual wheelchairs, and power wheelchairs, selected based on functional level, energy efficiency, and individual goals. Educational support services help children with spina bifida reach their academic potential. Individualized education plans address specific learning disabilities, accommodate physical limitations, and provide necessary services. Many children succeed in mainstream classrooms with appropriate supports, while some benefit from specialized instruction for particular subjects. Transition to adult care represents a critical period requiring careful planning and support. Adolescents must gradually assume responsibility for their own care, learning to perform catheterization, manage bowel programs, monitor for complications, and communicate effectively with healthcare providers. Vocational rehabilitation services assist with career planning, education, and job placement. Many individuals with spina bifida achieve independence, maintain employment, and live fulfilling adult lives, though some require ongoing support. Prevention through adequate folic acid intake represents one of the most effective public health interventions available. All women capable of becoming pregnant should consume 400 micrograms of folic acid daily from fortified foods or supplements, as neural tube closure occurs before many women realize they're pregnant. Women with previous affected pregnancies, those taking anti-epileptic medications, or those with other risk factors should take higher doses of 4,000 micrograms daily under medical supervision. Preconception counseling for women with risk factors allows optimization of health before pregnancy, including achieving good diabetes control, reviewing medications, and ensuring adequate folic acid supplementation. The pathophysiology underlying spina bifida involves multiple interconnected mechanisms. The primary defect is failure of neural tube closure, but secondary effects cause much of the clinical morbidity. The two-hit hypothesis proposes that initial neural tube closure failure represents the first insult, while ongoing exposure of neural tissue to amniotic fluid during gestation causes additional damage, explaining why prenatal surgery may improve outcomes. Exposed neural tissue suffers chemical injury from amniotic fluid constituents and mechanical trauma from fetal movements. The Chiari-de-Sas malformation develops through complex mechanisms involving small posterior fossa volume, possibly related to cerebrospinal fluid dynamics disrupted by the spinal defect, causing hindbrain structures to herniate downward. This malformation then contributes to hydrocephalus by obstructing cerebrospinal fluid pathways. At the cellular level, neural tube closure requires precisely coordinated cellular processes, including proliferation, migration, differentiation, and apoptosis. Multiple signaling pathways must function correctly, including those involving sonic hedgehog, bone morphogenetic proteins, WNT signaling, and retinoic acid. Disruption of any of these pathways can prevent normal closure. Genetic studies have identified numerous candidate genes, though no single gene accounts for more than a small percentage of cases, confirming the polygenic nature of susceptibility. Environmental factors likely interact with genetic predisposition through epigenetic mechanisms, including DNA methylation, which depends on folate-mediated 1-carbon metabolism. The neurological deficits result from both the malformed neural tissue within the lesion and secondary effects on normal spinal cord above the defect. Tethering of the spinal cord limits its normal ascent relative to the vertebral column during growth, causing stretching and ischemia that can produce progressive neurological deterioration even years after initial repair. Syrinx formation, where fluid-filled cavities develop within the spinal cord, can occur and cause ascending neurological deficits. Research continues advancing our understanding of spina bifida and improving outcomes. Genetic studies aim to identify susceptibility genes and develop better risk assessment. Investigation of folate metabolism and related pathways may lead to more targeted prevention strategies. Advances in prenatal diagnosis and fetal surgery techniques may expand the population who can benefit from prenatal intervention while reducing risks. Tissue engineering and regenerative medicine approaches seek to develop methods for replacing or regenerating damaged neural tissue. Improved shunt technology aims to reduce complications and failures. Enhanced understanding of neurogenic bladder and bowel has led to better management strategies preserving renal function and improving continence. Psychosocial research identifies factors promoting resilience and quality of life, informing supportive interventions. The natural history of spina bifida has changed dramatically over recent decades. Previously, many affected infants died in early childhood from renal failure or shunt infections. Now, with modern management, survival rates exceed 90% into adulthood, and quality of life has improved substantially. However, individuals face ongoing health challenges throughout life, requiring continued monitoring and intervention. As the population of adults with spina bifida grows, healthcare systems must adapt to provide appropriate adult-focused care, as many services traditionally existed only in pediatric settings. Long-term outcomes vary tremendously based on lesion level and severity, presence and management of hydrocephalus, occurrence of complications, and quality of care received. Mobility ranges from community ambulation without assistive devices for those with low sacral lesions to requiring braces or assistive devices for household or limited community ambulation with lumbar lesions, to primarily wheelchair mobility with thoracic lesions. Continence can be achieved in many individuals with appropriate management programs. Intellectual outcomes span the full range, with many individuals having normal intelligence and others experiencing varying degrees of cognitive impairment. Educational attainment has improved, with increasing numbers completing high school and pursuing higher education. Employment rates remain lower than the general population but have increased with improved accessibility and anti-discrimination legislation. Living with spina bifida requires ongoing vigilance, self-care, and engagement with healthcare systems. Adults must monitor for late complications including tethered cord, shunt malfunction, syrinx formation, declining renal function, skin breakdown, and orthopedic deterioration. Pain becomes increasingly common with age, related to musculoskeletal issues, neurological changes, or chronic pain syndromes. Maintaining physical fitness and healthy weight poses challenges but provides important health benefits. Mental health support helps individuals navigate the psychological challenges of living with chronic disability. The impact on families is profound, beginning from prenatal diagnosis or birth and continuing throughout life. Parents face difficult decisions, emotional challenges, financial burdens, and practical demands of complex medical care. Siblings may feel neglected or burdened but can also develop empathy and maturity. Family-centered care models recognize the entire family as the unit of care, providing support services, respite care, and counseling to address family needs. Parent support groups and organizations provide valuable resources, connections, and advocacy. Society's role in supporting individuals with spina bifida encompasses accessibility, anti-discrimination efforts, healthcare policy, and research funding. The Americans with Disabilities Act and similar legislation in other countries have improved accessibility and prohibited discrimination, though barriers persist. Healthcare coverage and access to specialized multidisciplinary care significantly impact outcomes but remain variable. Research funding supports continued advances in prevention, treatment, and quality of life. Spina bifida thus represents a complex condition spanning prenatal development through adult life, involving multiple organ systems, requiring multidisciplinary care, and profoundly affecting individuals and families. Tremendous progress has occurred in prevention through folic acid supplementation, prenatal diagnosis and intervention, medical and surgical management, and support services. Continued research promises further improvements, yet challenges remain in ensuring universal access to prevention and care, supporting individuals across the lifespan, promoting inclusion and quality of life, and ultimately preventing this condition entirely. Understanding spina bifida in all its complexity, from molecular mechanisms to lived experience, enables healthcare providers, families, individuals, and society to work together toward the best possible outcomes for those affected by this condition.